Bleeding tendency, part 2. Thrombocytopenia. What is the definition of thrombocytopenia? Thrombocytopenia means platelet count below 150,000 per cubic millimeter. How it presents? When there is thrombocytopenia, from history we may find the patient come and complain bleeding gums, epistaxis, post-surgical or intra-surgical bleeding, metrorrhagia or menorrhagia or excessive. This means excessive bleeding of during menstruation. On examination, we may find petechiae, non-palpable purpura, bruising, or ecchymosis. Hemarthrosis and deep muscle hematomas are rare in thrombocytopenia. It can happen, but it is rare. It is more in coagulation disorder, as we are going to discuss later. This skin rash represents the barbaric eruption and petechiae which we can find in patients with thrombocytopenia. It can be on the skin or on mucous membrane. Causes of thrombocytopenia. Thrombocytopenia can happen due to decrease in platelet production from the bone marrow or increased platelet destruction in the peripheral circulation or due to hypersplenism. Decreased platelet production from the bone marrow may be nutritional, as in case of B12 or folate deficiency, or marrow damage, as in aplastic anemia, chemotherapy, radiotherapy, drug-induced marrow damage, in case of incubation of the bone marrow by malignancy, as in case of metastasis, or primary bone marrow malignancy, like in leukemia, myelodysplasia, or congenital bone marrow aplasia, like in Alport and Fanconi syndromes. Increased platelet destruction. It may be immune or non-immune. Immune thrombocytopenia, like ITP, idiopathic thrombocytopenic purpura, may be post-viral, may be secondary to systemic lupus or alloimmunity, heparin-induced thrombocytopenia, drug-induced thrombocytopenia, and antiphospholipid syndrome. Non-immune thrombocytopenia, indisseminated intravascular coagulopathy, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, preeclampsia, and HELP syndrome. HELP is abbreviation for hemolysis, elevated liver enzymes, and low platelet count. There is other causes of thrombocytopenia. Drug-induced thrombocytopenia. Any medication taken by a person who develops thrombocytopenia can be considered as a potential causative agent for thrombocytopenia. So, drug history is very important in patients with thrombocytopenia. Heparin-induced thrombocytopenia is a special entity. It may be due to current or recent treatment with heparin. Other drugs associated with thrombocytopenia may be antibiotic, like cephalosporins, rifampicin, gold salts, analgesics, neuroleptics, diuretics, antihypertensive. Acute and chronic alcohol consumption may also be associated with thrombocytopenia. Hemodilution. Hemodilution, as in case of massive blood transfusion and cardiopulmonary bypass surgery, may be associated with thrombocytopenia. Factitious thrombocytopenia. This means there is no false thrombocytopenia. There is no actual thrombocytopenia, but it is clumps, platelet clumping on the blood film, and when we take the samples, this can be seen on the blood film and confirmed by repeating in a citrated sample using a citrated tube in exchange for the tube with editor, because editor allow platelets to clump together. In a hospitalized patient, drugs and infection account for the majority of cases of thrombocytopenia. Platelet sequestration, as in case of hypersplenism, which may occur in liver diseases and may be primary hypersplenism without any other cause. First, we are going to discuss immune thrombocytopenia, or ITP. Immune thrombocytopenic purpura is a clinical syndrome in which a decreased number of circulating platelets manifest clinically as a bleeding tendency, easing bruising purpura, or extravasation of blood from capillaries into the skin and mucous membrane. Although most cases of acute ITP, particularly in children, are mild and self-limited, severe bleeding like intracranial hemorrhage may occur when the platelet count drops below 10. ITP remains a diagnosis of exclusion. This means we have to exclude other causes of thrombocytopenia, as we mentioned before diagnosing thrombocytopenia as idiopathic or primary immune thrombocytopenia. Exclusion of other causes of thrombocytopenia if grounds for suspicion exist, like viral infection by testing for HIV, hepatitis C, hepatitis B, A, cytomegalo, Epstein-Barr, and others is indicated in at-risk population. Exclude other immune thrombocytopenia or secondary thrombocytopenia, like in SLE, antiphospholipid syndrome, B-cell malignancy, like primary chronic lymphocytic leukemia and large granular leukemia. Up to 5 to 10% of patients eventually meet criteria for systemic lupus erythematosus or another cause of secondary immune thrombocytopenia. So 5 to 10% of cases you find it secondary to another disease, especially systemic lupus. Most cases are females between 18 years and 40 years. Approximately 1% of patients with immune thrombocytopenia have coexisting immune hemolytic anemia, and it's called Evans syndrome. Smaller percentage have also associated immune neutropenia, which confer a less favorable prognosis. How we can investigate immune thrombocytopenia? First, by doing complete blood cell count. Isolated thrombocytopenia usually is the hallmark during complete blood picture. Anemia and or neutropenia may also present, and it indicate other disease. It means anemia may be due to bleeding, and the neutropenia may be found as an association with other disease, like in immune thrombocytopenia, like in leukemia, or like in autoimmune neutropenia. Increased number of normal or atypical lymphocytes on peripheral smear may reflect a recent viral illness. Clumps of platelets on a peripheral blood smear may be evidence of pseudo-thrombocytopenia. This diagnosis is established if the platelet count is normal when repeating the sample on a heparin or citrated tube. Role of bone marrow aspiration and biopsy in immune thrombocytopenia. The value of bone marrow evaluation for diagnosis of ITP is a matter of debate and still unresolved. Biopsy in patients with ITP shows a normal to increased number of megakaryocytes in the absence of other significant cellular abnormality. In children, bone marrow examination is not required except in patients with atypical hematological finding, such as immature cells like blasts on the peripheral smear or persistent neutropenia. In adults older than 60 years, biopsy is used to exclude myelodysplastic syndrome or leukemia. In adults whose treatment will include corticosteroids, a baseline pre-treatment biopsy may prove useful for future reference, as corticosteroid can change marrow morphology. Biopsy is performed before splenectomy to evaluate for possible hypoplasia or fibrosis. Unresponsiveness to standard treatment after 6 months is an indication for bone marrow aspiration. What is the treatment of immune thrombocytopenia? Most children and young adults with acute ITP don't require treatment, and the condition will resolve spontaneously, especially post-viral cases. Immune thrombocytopenic purpura relapses may occur years after seemingly successful medical or surgical treatment. Treatment of ITP. First line of treatment, corticosteroids, remains a drug of choice for the initial management of acute ITP. Oral prednisolone or prednisone, intravenous methylprednisolone, or high-dose dexamethasone may be used. Intravenous immunoglobulins. Intravenous immunoglobulins has been the drug of second choice for many years, especially in emergency situations, but it is an expensive line of treatment. Intravenous anti-D immunoglobulin. The mechanism of action of anti-D is not fully understood. However, following administration, anti-D coated red cell complexes saturate the FCY receptor site on the macrophages, resulting in preferential destruction of red blood cells rather than the platelets, therefore sparing antibody-coated platelets. Intravenous anti-D may induce immune hemolysis, especially in Rh positive persons, which is the most common adverse effect and shouldn't be used when the hemoglobin concentration is less than 8. Sporadic cases of massive intravascular hemolysis or DIC, renal failure, reported during treatment with intravenous anti-D. Rituximab or anti-CD20, it is a biological therapy and is third line of therapy. It is also an expensive line of treatment. Immunosuppressive drugs like mycophenolate, Mofetil, azathioprine, cyclosporin, also used as a steroid-sparing agent. In chronic refractory cases where immature pathogenesis has been confirmed and chemotherapy agent vincristine may be attempted. Vincristine has a significant side effects, and its use in treating ITB must be approached with caution, especially in children. What is the role of platelet transfusion in ITB? We don't transfuse patients with ITB except if there is a life-threatening bleeding. So, platelet transfusion may be required to control clinically significant life-threatening bleeding but are not recommended for any prophylaxis. If 6 months of medical management fail to increase the platelet count to a safe range, so the case now is chronic ITB, we have to consider splenectomy. And splenectomy remains the single best option to convert a patient with ITB into non-patient with ITB and change his quality of life. The timing of procedure depends on disease severity and responsiveness and side effect of therapy, risk of trauma and of the procedure, and patient and doctor preference. Thrombopoietin. Thrombopoietin receptor agonist, L-thrombopac or romiblastim. Maintain platelet count at safe level in adults with chronic ITB refractory to conventional medical management, especially after splenectomy. It's better to use it after splenectomy in case of chronic ITB. Thrombocytopenia of pregnancy. Pregnant women require special consideration for a safe delivery. If the platelet count is greater than 50,000 per liter, the risk of serious hemorrhage is low, but beginning prednisone, oral steroid, a week before delivery is a reasonable precaution if the platelet count less than 50,000 per liter before delivery. Treatment with oral prednisone and intravenous immunoglobulin is recommended as a pre-delivery treatment in critical thrombocytopenia. So as long as platelets above 50, there is no treatment. Below 50, we can try giving steroid, or in emergency situation, we can give intravenous immunoglobulin. Prognosis of ITB. 60 to 90% of adults with ITB respond with an increased platelet count after treatment with steroid and intravenous anti-D or intravenous immunoglobulin. Of those adults who don't maintain an increased platelet count and who require a splenectomy, approximately 2/3 have a sustained response and 10 to 15% have a partial response.